You can actually place our device, put it in the aorta, inflate the balloon, keep that soldier alive, get them on a helicopter, get them back to the far forward sort of hospital and trauma suites, get them, sorted out as far as the bleeding, pack their abdomen, really get the bleeding under control, start blood transfusions, and then they even go from that far forward hospital to a regular hospital, like a level 1 trauma center before that. So that's really, and before this was available, soldiers just wouldn't even make it to that point.
Welcome to this episode of the MedTech 101 podcast, and today we're talking about something that could determine life or death and the importance of emergency medicine. And joining me today is Dr. Adam Power, who's a vascular surgeon, and he's also an associate professor, whilst also working on a company which they started together called FrontLine Medical Technologies. So it's quite interesting, really. It's like the blend of everything, academia, entrepreneurship, and medicine. So welcome to the podcast, Doc.
Thanks so much, Rodney. It's a pleasure to be here.
Thank you. So yeah, just to get it started, just to start with your background, really. I mean, like your life as a vascular surgeon, like what made you choose vascular surgeon, and well, what made you choose to be a vascular surgeon, and what perhaps would you say is the definition of vascular surgery? Because I'm sure a lot of people will be hearing this for the first time.
Yeah, no, thanks, Rodney. So I'll go back to sort of why I chose it. I mean, I was doing undergraduate science and not really sure what to do, and being a doctor was one of the things that you could do. And I was drawn to helping people. I have always wanted to be in a career that helped people. So I was drawn to medicine. I have an identical twin brother who is doing this journey with me, and we both applied to medical school. I like to say that I got in first, so I got in. We both got in the same year. We were in the same medical school class, and in medicine, I was actually quite surprised about how inexact it was. I was a scientist. I was quite precise, and medicine was anything but that. It was, and I didn't like that, and so I was drawn to surgery because surgery was more precise type of medicine than anything else, and so I ended up becoming a general surgeon first, which is mainly an abdominal and torso surgeon. And included in that is a trauma surgeon. So I spent 5 years in undergrad becoming a general surgeon, and my brother was a urologist. And then I decided at the end of general surgery that I was quite interested in vascular surgery. And so I did a fellowship specialized training in vascular surgery. So what the heck is vascular surgery? Vascular surgery is dealing with the blood vessels of the body. It used to be split. It used to be cardiovascular surgeries where it was you do heart work and you do blood vessel work. And somewhere, I think in the 70s or 80s, they split it to heart, cardiac surgeon, and vascular surgeon is anything outside of the heart. And so that's really what I work on. Typical procedures that we would do is peripheral vascular disease, so bypasses or stents in the leg for peripheral vascular disease, carotid disease, where you scrape to prevent stroke, scrape out the artery, put a patch on it, and aneurysms, abdominal aortic aneurysms, thoracic aneurysms. Those are typical things that we would treat. But obviously, just going to say, to draw it back, to segue back to what we're talking about today, is where does emergency medicine fit in all this? Is if you injure the large blood vessels of the body or you're bleeding out, that is, many surgeons are trained to control that. But as a vascular surgeon, we tend to get involved in the very complicated cases. And that's sort of what was the genesis of even being involved with emergency care in the first place.
Nice. And just to throw in a quick, interesting fact about vascular surgeons for the audience is that a few weeks ago, a few months ago, I did an interview with the CEO of a medical device where they basically enter the body with through minimum invasive techniques. So by like surgeons would like cut a small incision in the leg, and then you would sort of like use these robots to sort of like navigate your way up the blood arteries or veins all the way to where perhaps a blood clot would be, and or where you perhaps may want to insert a stent. And just a quick question, like how difficult is that procedure, or do you make use of that technology, or what's your preferred approach? Just out of curiosity to know what your day-to-day life is like as a surgeon.
Yeah, that's I mean that's great, and I see that in the future. It's I mean right now like that's automating what we do manually every day. And so we get and those are often the Achilles heels of a lot of these procedures is there's so many variables in treating a patient endovascular and where it can go wrong or where you might have trouble. Automating that sort of just makes it just takes away a lot of those variables and smooths them out. So we'll get access, we'll navigate with different catheters and wires. It takes us a while. Like I mean, if you had in advance something that was doing that would save a lot of time. It would increase the safety of a procedure. So I definitely see value in that. But I'm doing a lot of it manually these days. Yeah.
Well, Well, that's a lot of work, and no, thank you very much for answering that. And going back to what we're talking about, sort of in terms of like emergency technologies, the company you started, or you part of FrontLine Medical Technologies. Like, what exactly are you guys about? Because I see you've been running for almost 8 years now, and you're working on a lot of bleeding control, etc. So, what could you tell us about FrontLine Medical Technologies?
Yeah. And I guess just to draw the very quick parallel to what you just described about, the automation of these endovascular procedures and what I do manually, really what we're trying to do is to even simplify it even more. And so that's what our company is trying to do is to do a minimally invasive endovascular procedure with trying to not think about it and just to simplify it and to have even non-surgeons, even non-physicians potentially being able to block the aorta, which is crazy. So that was really what our goal was. Um, so to back up, we started. So I'm a vascular surgeon. I've always been interested in inventing, filed lots of patents. Consulted with industry. But if I was ever going to see something, if I was ever going to be able to use something in my hands that came out of my head, I was going to have to do it myself. So I was very lucky to partner with a PhD biomedical engineer. I know you're a biomedical engineer, Dr. Asha Parekh, who really has been the heart and soul of Frontline for the past 8 years. She's worked full time. The company, I have a daytime job, but I work in between and in the nighttime on Frontline. But it's really been her and building this from the very beginning. Um, the I and I'll just give you an example of a case where the problem is really highlighted. And so, if you have a patient that is bleeding out, essentially, if you're bleeding out in your arm, you can put a tourniquet on, or your leg, you can put a tourniquet on and stop the bleeding. If you're bleeding in the torso region, you can easily empty almost your entire blood volume into the chest or into the abdomen and you die. Yeah, so that's called non-compressible torso hemorrhage. And when you hear about people not making it to the hospital with major hemorrhage, this is usually what they're dying from. Those are car accidents or penetrating trauma. In the US, it's a lot of penetrating trauma, gunshots, those types of things. And external to the US, it's a lot of blunt trauma, motor vehicle accidents. And then there's obviously the military side of things where you get different injury patterns. So I had a patient that when I was a resident who essentially got stabbed in the heart across the street from the hospital, and brought them into the emergency department. We had to open up their chest, put a clamp on their aorta, and sort of fix the problem. That did not work for the patient. The patient unfortunately died. That's called an emergency room thoracotomy. The idea with that is if you've lost a bunch of blood and you're not perfusing your brain or your heart, that's where you go into cardiac arrest. And so if you short circuit it by placing a clamp on the aorta and it just circulates blood to the brain and the heart, you sort of sacrifice the lower half of the body for a few minutes, up to even a half an hour sometimes, in order to get the patient to definitive care, and then you can release the clamp. But that is a huge thing to be doing, and you certainly can't be doing that roadside. Um, so if you can do something like that minimally invasively, that might really help some patients. You might be able to not even just do it in the trauma room, do it pre-hospital. And so if you can imagine accessing, just like we were talking about earlier, the femoral artery, and putting a balloon up inside the artery and inflating a balloon from the inside in the thoracic aorta, it turns off the tap to the abdomen and lower extremities and allows blood flow to circulate to the brain and the heart. It buys you time. It's like a bridge to definitive care. And so if you're able to do this big emergency room thoracotomy and clamping minimally invasively, you can potentially save a lot of patients. And so that was really where our product, the Cobra OS, came in. The first devices that were developed for this type of procedure were as big as my baby finger. And when they went into the femoral artery and up into the thoracic aorta and pulled it out at the end, it was a huge hole in the artery. And so you had to have a surgeon to fix that. And as the technology developed, it got more and more, the profile was smaller and smaller, to now to the point where the Cobra OS fits through a tiny little IV in the artery in the groin that goes that you and you know when we did our first in human studies, that whole thing can be accomplished in average about 70 seconds. So you puncture the artery, get your initial sheath in, which has a valve on it, and place the device and inflate the balloon. It's that simple and can be done that fast to save a patient.
Well, wow, that's really interesting. I think just to even to simplify some things and come back to some points, to rewind a little bit, because it's a lot of information that was exciting to hear. Is
Yes.
uh in terms of preventing cardiac arrest, and how would you say that, what's the impact of what perhaps would be called like hypovolumic shock? I think it's a bit of a tongue twister, but like by blocking the blood flow that goes to the brain, does that buy more time to prevent this kind of shock? Because we understand that the body like is responding to a lot of things when someone is hurt and stuff.
Mm-hmm.
What exactly is the benefit of or the full
Mm-hmm.
extent of support that the body needs when someone is sort of like emergency, and what perhaps for people listening right now, if they've someone who has gone through this, like what's the most important thing to do to prevent that blood loss
Mm-hmm.
within the abdominal area, as you said, because you can quickly tie it like a rope or anything, or a belt, to stop that blood loss. So I'm kind of curious to think that what other things is it benefiting besides preventing cardiac arrest and all these types of shock. I don't know if you could perhaps give us a bit more insights on that, and for people what to do, as from a doctor's point of view, if they
Mm-hmm.
find themselves in such a situation.
Yeah, no, for sure. There's definitely a rabbit hole you can go down with this stuff, and even as a physician or a layperson, you may not actually have realized why people die when they're bleeding. And so, what actually happens is the blood, because you need to keep your heart alive to keep it pumping, and your coronary in your heart is just a muscle, and your coronary arteries supply that muscle with oxygenated blood. If you're bleeding, like say from a liver trauma, if you're bleeding out into the abdomen, and the amount of blood in your circulatory system gets so low that you're not adequately oxygenating your heart because there's not enough blood flow going to the heart muscle, it goes into arrest. The second thing to think about is, okay, great, your heart's alive, but a lot of these patients that go into cardiac arrest have, like, their heart's alive and their body's alive, but their brain's now dead. And so first priority heart to keep the heart alive, second priority brain to keep the brain perfused. And amazingly enough, you can sacrifice the whole rest of the body, kidneys, liver, legs, for a short period of time, as in 20 to 30 minutes. You can do that, and then get the liver bleeding under control, and then release the sort of clamp or release the balloon. But what does that clamp in the thoracic aorta do? You think about what's happening above the balloon is it's keeping flow to the brain and the heart. What's happening below the balloon is it's blocking off the blood and also allowing clots to form in the liver and everything else. And so it's providing that double purpose. But the other thing it enables you to do, because you've got that bridge, what happens during that bridge? Resuscitation. You're giving that patient blood. Pre-hospital, we're starting to give whole blood. You're allowing transport to definitive care. So sometimes you're on the battlefield or roadside. You need to get them to a surgeon to fix them. That's the bridge. Those are the things that are happening sort of in between and allowing patients to get to hospital for that definitive care.
That's really insightful. I think, and I think that explains a lot of things in terms of why emergency care is so important, really. And looking at what you guys are working on right now, how would you say perhaps adds value to in terms of the technology you're adding? What exactly has been happening? What has been the traditional way of doing things, which you have mentioned, opening up the person and closing them up? But in terms of like emergency situations where like you're on the battlefield and there's probably shells of all kinds of ammunition around you. For those people going into those kind of environments and situations, how is your technology adding value to them? Because I think obviously this is going to increase the survival chances of a lot of soldiers or first response personnel, like police officers, victims of gun wound shots, and also even the medical practitioners attending these people lives also be improved a bit. But how is that going to be happening in terms of like what's exactly on the market at the moment, and what makes you guys so special? Because I think what you guys have is quite interesting, or in terms of what you continue developing.
Yeah, and we haven't said the word yet, but it's important to say the acronym that's associated with this, which is REBOA, REBOA, is resuscitative endovascular balloon occlusion of the aorta. That's sort of, if you were Googling this or just wanted to know more information, then using that word, you get some more information. But this was born on the battlefield. I mean, it really started in the US military, because they didn't want to be opening up soldiers on the battlefield. They wanted something more minimally invasive to save these soldiers. And specifically for soldiers, you think soldiers wear battle armor. So they have armor over their torso, they have armor even on their legs, but on the joints, like their arms or in the groins, their legs, that's called the junction. And if you step on a landmine and shrapnel goes, everywhere, it can come up through these junctional areas, like into the pelvis. So through the groin into the pelvis. And those patients, unfortunately, are literally just bleed out there on the battlefield waiting to be evacuated. And so if they had our device there, and there are some groups around the world that actually have these devices on the battlefield, You can actually place our device, put it in the aorta, inflate the balloon, keep that soldier alive, get them on a helicopter, get them back to the far forward sort of hospital and trauma suites, get them, sorted out as far as the bleeding, pack their abdomen, really get the bleeding under control, start blood transfusions, and then they even go from that far forward hospital to a regular hospital, like a level 1 trauma center before that. So that's really, and before this was available, soldiers just wouldn't even make it to that point. And so there has been a lot of work to develop the systems to enable this to happen. I say it's an easier procedure than, opening up their chest, but it's still a difficult procedure. You need to have the device on you. You probably need to get access under ultrasound. Like, these have to be practiced, and you have to, if you're only doing it once a month or once every couple of months, like that, that is difficult to do. This skilled procedure. So there's a lot that goes into being able to save one soldier. We were quite happy as a company. We donated some medical devices to some surgeons in Ukraine, and they were actually able to use it to help save some soldiers. And they just published it in their journal about the first use of Reboa using the Cobra OS and another device. Um, Literally, of soldiers on the battlefield, and that was really a great thing for our company to be able to help soldiers on the battlefield, especially what's happening in Ukraine.
Yes, I understand, and I think I think that's what makes medical devices quite interesting. Really, the fact that you can actually see the impact of the medical devices you're creating and or working on, etc., in the field, helping a lot of people. And I think that's really interesting. And then you mentioned doing donations to them, so obviously that talks about your system, the Robola system, being basically like FDA approved or approved for use, or are you but in terms of market access and market availability or the size of the kit, I'm sure a lot of people will be wondering right now as to how big is it, where is it available, what's the sort of like the approval markets are for this particular product. What would you say to those people?
Yeah, so like the kit itself it actually comes. It's almost like a file folder, but it's thick, the device comes with it, as well as the access kit to get the valve sheath in, and a syringe. So literally, if you showed up as a soldier with our little box, you could even use canteen water, because you use typical sterile saline to inflate the balloon. But if you were in a pinch, you'd basically have everything available to be able to place the device and save someone, except for the water. Um, we have approvals. We started out with North American approvals, so that was FDA as well as Health Canada approval. I wanted, Canada is a smaller market, but it's an important thing for us as a Canadian company. And we've saved multiple patients in my particular hospital with our device, which I'm very proud of. That was a big day to be able to use the device that Asha and I came up with to actually save a patient in my hospital. That was quite a special time. But we have that approval. We just got CE mark approval through the new MDR process, which was not easy to do. The MDR, as I'm sure you've talked to many guests about, has certainly increased the difficulty for approvals in Europe. But we were able to get approval. We're a Class 3 medical device through that, a Class 2 medical device in North America. But we also have approvals that we should be announcing soon in Australia, and we also are approved to sell in the UK as well. That's fairly recent. So we have other approvals that we're attempting, but that's keeping us busy right there.
Yes, I can imagine because I think for a lot of people listening right now, to get like a CE mark, to get an FDA approval, to get approval in Australia or the UK one, which they call the UKCA approval, it's it takes a long time. It takes a long time to get to this point. So I'm really happy to hear that. I'm sure a lot of people are happy to hear that, and it means that you can now basically ask your doctor about this, and they can just say, okay, cool, we'll probably try it in this hospital or whichever emergency care units hospitals might have. So now, congratulations on that, and I think it's taken years of clinical data, trials, tests to get to this point. So, and I think like it's the most exciting point for anyone involved in medical devices because you can work on something for years and still hope that we just get the approval, and then you have to work to maintain those, and that's really good. And then like sort of like getting towards the end in terms of like the question that I wanted to ask you, which is something traditional that I do on this podcast, is to say that like what you've described right now to a lot of people sounds like a futuristic technology, but there's actually technology that's now on the market. So the question is then, like, if this is already what's on the market and it sounds so futuristic, what are your thoughts on the future, like in terms of emergency care for people, not just soldiers or like accident victims, etc. But like, yeah, what are your thoughts on the current market right now versus the future in terms of where do you think the market is leading to at the rate of things?
Yeah. No, that's a great question and something that we have to keep an eye on because obviously we're developing future products as well, and so we have to strategize about where this is all headed. We talked about trauma care. One thing that is up and coming that is existing, but we haven't chatted about, is postpartum hemorrhage. And so the same idea is it's almost like when you have postpartum hemorrhage is like a trauma sometimes, and mothers can bleed out with different conditions that happen during delivery. One of them is placenta accreta, where the placenta grows into the uterus. Those are really difficult cases, and so there are hospitals in the U.S. and in Europe that are using our device to help stop the bleeding during these cases and help women keep from having an unplanned hysterectomy and decrease blood transfusions and hopefully help with mortality. And we also are we're supplying devices for a trial that's happening in Africa, in Uganda, to help with postpartum hemorrhage. So that is something that's up and coming that we're really excited about. And it's the simplicity of the device, the smallness of the device that enables it to happen. So really the answer is more applications for the existing technology before we get to the future. The one that is a really exciting application that is we're probably going to see in the next 2 years is, we talked about cardiac arrest from bleeding, but what about cardiac arrest for non-bleeding? That's a huge problem all around the world. And so if you have a cardiac arrest outside the hospital and somebody starts CPR, you only have a 1 in 10 chance of actually making it through that whole process and out the other side and still alive. Amazingly, if you put in a device like ours into the thoracic aorta when you're doing CPR, it increases the effectiveness of CPR, because CPR, you're pushing blood to the whole body. But if you put a balloon, then you short circuit things and you're pushing blood directly into the heart to restart the heart and keeping the brain alive, brain perfusion. And so by doing that, you can actually increase ROSC, return of spontaneous circulation, or getting patients back. There's a randomized controlled trial going on in Europe right now. If it becomes positive, using this device for non-bleeding applications will just explode, and just help so many patients. I think the future, though, is we, it was a few years ago we talked about personalized medicine and all this other stuff. We don't use those buzzwords so much because it's a lot of AI and machine learning and everything else. But what I truly think is we're going to be able to better select patients. And so we're going to get personalized medicine through, AI machine learning is going to say, it's going to go bing, bing, bing. This is the patient right here that needs this device. Because we're kind of flying blind right now about who's going to benefit, who's not, and that those sort of that about the because patients, especially in trauma, have so many injuries and patterns and everything else. So, I mean, that's where I think the future is going to hold, is going to help us better select our patients.
Well, no, that's really interesting. And just one question that I had really about the future: do you think this could be something that ends up being part of every sort of like home's first aid kit, or is it something perhaps that requires that technical expertise that surgeons carry?
Yeah, I mean, if you really think about the future, and it's then absolutely, if you just pushed a button and somebody's aorta got blocked, safely for a short period of time, that enabled you to quickly zip them off to the hospital, fix the problem, and then deflate the balloon. I mean, that that blocking someone's aorta is a hugely impactful thing, and you can really help a patient. It's making sure you don't block it for too long, and then that particular device causing complications that you weren't accounting for. If you could do it all safely, absolutely, I can see this happening and be in us doing it in many patients for many different reasons.
Nice, nice. Now, thank you very much, Dr. Adam. I think that really explains a lot, and this was really informative for people. And obviously, what I'm going to do is, well, after this, is I'll be putting your like the link for your website below this, your contact details, and just for people listening, are you going to be attending any upcoming conferences or any places where perhaps people could meet up with you?
Yeah, no, we if you see any trauma conferences, we usually have representation, whether that's in Europe or
Nice.
in North America. So anything with trauma in it or emergency medicine, you'll likely find us there.
Nice, great. Sona, thank you very much for today and for coming on the podcast. I thought that was really interesting, and I learned a lot, and I'm sure a lot of the guys listening today also learned a lot or learned about a new technology, perhaps which they had not thought about.
No, it's been a real pleasure. Thanks so much for the time today.